So let's start. Financial disclosures, there's none, but there's just like yesterday for the birdshot talk, there's a lot of medication mentioned here are off-label uses. And the outline of my talk, I'll go into a little bit introduction, and we'll do a little bit epidemiology, talk about clinical exam, the SUN nomenclature, talk about diagnostic testing, and then we'll go into medical and surgical management of uveitis and its complications. So, epidemiology, uveitis is the third leading cause of blindness worldwide, and the prevalence is low compared to all other systemic or even just ocular diseases. But we see them, and they're especially when you're a tertiary center, you can get pretty busy seeing uveitis patients and uveitis patients alone. In the US, it accounts for 10% of legal blindness each year, which equals about 30,000 new cases a year. And it's predominantly, what's special about uveitis is predominantly it affects younger people, working age population. So the burdens is pretty multifaceted. And the socioeconomic impacts, there's a paper that came out recently in German that says 69% of these pediatric uveitis patients had systemic disease, and 2/3 of them have complications at presentation. A little less than half of them say that they had quality of life reduced, and 1/4 of them say they had reduced recreational time. 30% had negative influence on education, and 12% needed repeat class or change school, and those are just kids. And think about people, adults who are working, who had to bring money home and feed their children and parents. This is an estimate on how much, not just uveitis, but ocular disease had a socioeconomic impact on, and this is the United States data, and at all ages, you can see the number down here is 138 billion. These are in millions, so these are 138 billion. If you look at just looking at the bottom, the two groups, the 0 to 17 to 18 to 39 age, you're talking about almost $30 billion of costs a year just from all the burdens associated with ocular diseases. And I think this is the first paper that focused on ocular diseases in the younger population, at least in the United States. So as you know, it's associated with a lot of systemic diseases, RA, JIA, seronegative spondyloarthropathy, sarcoid, MS, lupus, VKH, Behçet's, ANCA, vasculitis, and scleroderma, and many, many, many more. And the vision complication, as you know, there's a lot of different things that can happen with uveitis, and just treating the inflammation oftentimes can make a lot of these things better, but not completely. So you still have to know how to manage them surgically. So you have to, just being a uveitis person doesn't mean you are not a surgeon. You're not just a chemotherapist. To be a comprehensive uveitis specialist, you really have to be a good surgeon as well, and really know how to manage all the complications that can come with it. Just a couple papers on the impact of chronic inflammation. This is a paper from London, and this is from Moorfield, and they had looked at 140 children with uveitis, and 69% of these children had cataract on presentation. And they found that the main factors associated with developing cataract were related to chronic active inflammation. And in this paper, they say the greater number of flares, cystoid macular edema, and posterior syndicate all are related to formation of cataract. And they actually say, if you have to use topical or systemic steroids, do it, because they actually were less likely to develop cataract than if you just let the inflammation go on and on if you're afraid of using steroids on these children. But of course, we know it's not the preferred way to treat it, but if you're dealing with the children fresh, you're seeing a very acute flare, you go ahead and treat them with steroids, do as aggressively as you think it's necessary. And just more paper on complications, 19% of patients coming with vision loss, 10% has glaucoma, and this is based on the Kaiser, a review of 844 uveitis patients, so all pretty new data. And I would say these data still hold true after the last 20, 30 years. And it's unfortunate because after all these years, after all these availability of the biologic therapy, after we train all these uveitis specialists all around the world, the complication rate from the uveitis are still pretty similar. They haven't really gone down through the decades. And so that's why we keep on working, that's why Dr. Foster keeps on doing research, keep on going around the world, give lectures for that purpose. We want to educate more people, make people at least feel more comfortable diagnosing and treating, and at least know when to refer to the tertiary specialists. So how do you assess a uveitis patient? A thorough history taken is number one, and review a system. And if you go to this website here, that's our company's website. We actually have a very good, thorough questionnaire that Dr. Foster made years ago when he was at Mass Eye and Ear. And this is free for all to download. So you can, it's 9 pages, and every new patient that comes to Mercy, we have our new patient coordinator send the questionnaire to the patient and have them fill out. A lot of time they say, why are you making me fill out 10 pages stuff before you even see me? But a lot of patients actually appreciate it because they found that it makes them remember things, a lot of things that may have happened in the past, they may not notice. They actually help them recall. So you feel free to download. I think it's very helpful when you see a uveitis patient, just print out a stack of it and just give it to the patient. A lot of the time that questionnaire will help you find a lot of clues that might help you lead to a diagnosis or at least narrow down the diagnoses. And of course, besides these question history, you have to be an ophthalmologist. You're doing an examination, you do a diagnostic testing that we all very familiar with, and of course, serologies, radiographic studies, and finally, consultation if needed. So physical exam. This is a physical exam for the ophthalmologist. We're not asking you to do too much, but don't be shy to ask your patients to, maybe take out a couple articles of their clothing, look at their nails, look for nail pitting, have them roll up their pants, look at their shins, looking for different things. Look at the nose, look at their hair. You'll be surprised a lot of things you're going to see, and patients may not even notice. They might just write it out, they're just a little bug bite, but actually may not be. And so before you even sit them down at a slit lamp, try to look at the rest of the body as much as you can. And Dr. Foster has always taught me to do that, and all the fellows that come through Mercy, we put so much emphasis on physical examination because we are all physician, internal medicine physician at heart. So the sun classification, now you talk about anterior, intermediate, posterior, and if you can subcategorize it into different locations. And why is this so important? Because just by knowing the location of where the most prominent inflammation is, it really helps you narrow down the diagnosis significantly. Now, it also helps you save a lot of money in terms of testing. I mean, of course, you can do the shotgun approach and just order every single test in the world, but by really knowing and correctly describing where you think the inflammation is most prominent, it helps you narrow down the diagnosis in your mind, and also when you communicate with your colleagues, when you refer to a uveitis specialist, it really helps us understand what you're seeing, what you're describing. And it's also important to pay attention to cornea and sclera as a retina specialist. And why? Because if you see uveitis with cornea involvement, there are the differential diagnoses. It really helps cut down a lot. And I'm happy to, if you guys want these slides, I'm happy, just email me. I'll give you my email later. Just feel free to email me. I can send you the whole presentation here. If your sclera is involved, that really narrows down. You have to think about scleritis, and there's much more, as you know, scleritis is more serious, and you have to think about the other kind of vasculitic syndromes. Now, the anterior inflammation grading is very important, and we all do it all the time. We sometimes go to 1.5, 2.5, 3.5. I even do 0.75 grading. But the sun nomenclature doesn't go to the exact gradation, but it does have the standard grading scheme here that you should follow. And flare is also important, but probably in anterior segment, I think cells are probably a little more important than flare, because flares tend to be present anyway, especially if somebody's chronic uveitis, especially in the JIA patient, you'll always have some sort of flare in their eye after years of chronic inflammation. So anterior chamber, the cells are, I think, more definitive in terms of telling you how the inflammation is going. Now, the posterior is different. Posterior, the cells are not as useful because a lot of them are trapped in the vitreous, and so the haze are a much more important the gauge. Now, the sun nomenclature is based on what Dr. Bob Nusenblatt from NEI, National Eye Institute, years ago proposed. The only difference is that instead of Dr. Nusenblatt called, I think he said trace, and the sun nomenclature just calling 0.5 plus, but everything else are the standardized photos shown here, and you can easily find these online. And we always have them in the exam room so our fellows can grade them correctly. Now, the course of inflammation is also pretty important too, and you have to describe it correctly. The duration, if it's limited, that means less than 3-month duration. If it's more than 3 months, you talk about persistent. Now, if it's acute, you're talking about sudden onset with a limited duration. When it's recurrent, so recurrent and chronic a lot of time got thrown together, but really, if you want to be accurate about it, recurrent means it's repeated episodes separated by periods of inactivity without any treatment, and sometimes these can go on 3 months in duration, more longer than 3 months in duration. In terms of the inactivity, when chronic, that means there's even after you discontinue the treatment, discontinue your topical or systemic steroids, the patient within the first 3 months they have inflammation again, and there's always some sort of chronic flare going on. That's when you describe as chronic. And why is it important? Because when you see different kind of courses, that again helps you narrow down the diagnosis. When it's acute and explosive, you're thinking about maybe B27 associated seronegative spondyloarthropathy, you're thinking about Posner, toxoplasma, and Alphamaitis, Behçet's. When it's chronic, you talk about JIA, you talk about Fuchs, sarcoid, syphilis, and the masqueraders like lymphoma. And when it's recurrent, you think about herpetic. Again, HLA-B27 is recurrent. And when you see a white and quiet eye, JIA is, I think, most famous because a lot of these kids come in with inflammation in their eye and they have no pain, they have no redness, and they just maybe have some blurry vision. And that's why there's such an important emphasis placed on seeing JIA patients regularly just to see any undetected inflammation. Now, granulomatous and non-granulomatous is very also important too. When you look at the cornea, you want to look at molten KP, and that's usually granulomatous. And you can look at the fine stellar one. What about iris nodules? The COPE nodules that you can see in both granulomatous and non-granulomatous anterior uveitis. So that's what made, so in Fuchs, people with Fuchs heterochromic iridocyclitis, you can get this kind of nodules at the pupillary margin, and sometimes that's what makes Fuchs get confused with granulomatous uveitis. So just be careful when you see nodules at the pupillary margin. It could be in both. It could be a granulomatous or non-granulomatous nodule. Whereas when it's on the surface of the iris, Busaka nodules, that's granulomatous. And finally, of course, you have the choroidal granuloma. That's granulomatous uveitis by definition. Now, why is it important? Because when you're talking about granulomatous uveitis, again, your differentials are much narrower. You're thinking more along the line of infection, but of course, in terms of autoimmune, sarcoid is the big one, and sympathetic ophthalmia and VKH are the other two. And then you also have to worry about lymphoma or systemic cancer metastasis to the eye. Now, what about differentials of that uveitis with high IOP? Again, it's more limited, so that's why it's important that you don't just look at the front and then look at the vision and then skip the IOP. You pay attention to it. If there's a big difference between the two eyes, then that's probably ocular hypertension. So you think about herpetic, you think about sarcoid, toxoplasma, syphilis, lens-induced, UGH, the uveitis glaucoma hyphema syndrome, and then again, the masqueraders of these conditions include pigment dispersion, Schwartz-Matsuo, as we know as retina specialists, and then also acute angle closure. People can come in with a little bit of flares, a little bit of cells, and they have high IOP, but you're actually not seeing real uveitis. It's actually just angle closure. Now, retinal vasculitis is another thing that we see a lot, and it's also important to describe retinal vasculitis correctly too. So you want to describe, is it more arteriolitis or is it phlebitis? And here's a picture of a patient I just saw very recently, and the picture on the left you can see is mostly artery that's involved, right? The veins are actually not very leaky at all, but it's all the arteries and the second and third degrees of arterial structures. I'm a big fan of Heidelberg because or any sort of optos, any sort of wide angle, wide field imaging, because you're able to see a lot of peripheral vasculitis that may not be apparent. And a lot of time we go with peripheral vasculitis as a gauge of how the patient is doing, and we do adjust our systemic chemotherapy based on what we see in the periphery as well. And here is the differential diagnosis for retinal vasculitis that involves artery, vein, or both. And that, again, recognizing correctly, describing what you're seeing really makes a big difference. In-office testing, we basically have to do everything. You try everything. I mean, whatever you think that's suitable and that's appropriate for the patient, for the scenario, for the history, you do it all. And in our office, we have pretty much all the toys we need for uveitis patients, and that includes visual field, OCT, ERG, UBM, and B-scan. And serologies, these are typically the tests that we do for patients when they come in here and somebody else has already done the workup, the standard workup, and we will add a few more, but these are some of the most common serologies that we will order. Why do we do all these? Really, I think the goal of doing a serology is sometimes you just don't know whether something is infection or is it autoimmune. Even if you can diagnose somebody with an autoimmune diagnosis, say, oh, you're rheumatoid, oh, you had lupus. It doesn't matter, because at the end of the day, as long as you can rule out infection and you have a couple elevated autoimmune markers, you can pretty be sure that you're dealing with an autoimmune phenomenon. And so the treatment ultimately is all the same, whether it's idiopathic or is there a systemic syndrome that's happening. The treatment is pretty much the same route. You may eventually need a uveitis person that's comfortable with chemotherapy, or you need to find a rheumatologist friend to help you manage the patient. Of course, if there's a systemic syndrome, if it's life-threatening, that will make you pull the trigger earlier on systemic immunosuppressive therapy. But I think it's important to do all this serology. Sometimes even just with one elevated marker, it can guide your treatment very, very differently. Now, radiographic studies, chest X-ray, we do typically when it's granulomatous uveitis, I do chest X-ray. I don't just order chest X-rays on everybody. I mean, it's easy, it's cheap, but I prefer to do my workup first and then see the patients back. Usually all that workup I just show you takes about 2 weeks at least in Boston area, and we tell patients to come back in 2 weeks. We see them. If their uveitis isn't blinding and you feel comfortable waiting a little bit, usually what happens is a new patient comes in here, we say, yeah, just keep doing what you're doing, keep the topical steroids every hour, and let's draw 20 tubes of blood from you, and then we'll see what happens. So we usually have them come back in 2 weeks, and that's pretty much the standard thing we do. And that also gives us 2 weeks to read on books and try to look at case reports, so if there's something funny going on. But if they come back and they say the lysozyme, the ACE is high, then you can order the chest X-ray to look for sarcoidosis, but you don't have to always get the radiographic studies right away. Lumbosacral spine X-ray, of course, is good for seronegative spondylar arthropathy. CT scan is good for any suspicion for foreign body, lymphoma, and also if there's a strong suspicion for sarcoidosis. If you see somebody with bilateral chronic uveitis, we sometimes will just go straight to CT scan, even without any respiratory symptoms. And since we're on sarco, I mentioned the Gallian scan as well. It is the scan that can detect glandular uptake activities in the different lacrimal gland, the submandibular gland, and the hilar lymph nodes. And the Gallium sometimes is pretty good at picking up sarcoid that's otherwise not seen on chest X-ray or CT scan. And the MRI is also good for MS and also intraocular lymphoma. Now, what do you do? So the next sections I'm showing you is initial workups when medical history is unrevealing. So that's after you give them the questionnaire, okay, and everything's no, everything's negative. So this is what we usually do. When it's first episodes, non-granulomatous, as you probably already know, is anterior uveitis, non-granulomatous. You don't have to work them up. You can just let them go, treat them with steroids, and keep your fingers crossed, hoping that it never comes back again. Now, if the second episodes of non-granulomatous anterior uveitis and their history is completely negative, then these are the things that we usually get. CBC, set rate, ANA titer, FTA, ABS, and RBR. Syphilis is always syphilis is always a possibility, right, in uveitis, so you have to rule that out. And HOA-B27. The interleukin-2 receptor is something a little newer, and we've been doing that a lot in our office, because when we find that interleukin-2 receptor is high, that usually tells you that's more likely to be an autoimmune condition. Now, as granulomatous uveitis, then you're looking at CBC with differentials, you're looking at ESR, you're doing ACE and lysozyme, syphilis workup, quantiferon GO, PPD, and chest X-ray. Intermediate uveitis, you look at Lyme titer. And again, that's probably more coming from the northeast of United States. Lyme is always something to consider. And we're talking about ACE lysozyme, syphilis, Toxocara, cat scratch, MRI, especially with a female, youngish female with vague symptoms, and HOA-DR15, because you can see that in intermediate uveitis who are likely to develop MS later. And the DR15 is also important because if you ever want to start somebody on immunosuppressive and you want to do Humira or Remicade, the TNF-alpha inhibitor, you want to avoid it in patients who have HLA-DR15, because it's been shown now with TNF-alpha inhibitor, you can potentially trigger someone's demyelination. And whether it's truly a causative effect or it's just unmasking something that was going to happen later is still to be decided. But if somebody has HOA-DR15, a young female with some sort of, even if they don't have any neurological symptoms, I think I will be less likely to put them on Humira or Remicade, and I will try to go with a traditional anti-metabolite, methotrexate, Celsep, or maybe other infusion therapy, but just stay away from the TNF-alpha inhibitor. Now, speaking of that, I think the quantiferon GO TB test is always important to get, because if you ever want to start your patient on TNFL inhibitor, the pharmacy will need the quantiferon GO anyway. So I think quantiferon GO should be done on all patients, just even if it's autoimmune, soonish they will need that titer before they can start a TNF-alpha inhibitor. Posterior uveitis or pan-uveitis without any revealing medical history, then you're talking about CBC with differential. You don't have to really go very aggressive on testing these, because a lot of these, unless it's definitive infectious, a lot of time it just turns out to be autoimmune. And retinal vasculitis, these are some of the tests we would get. And we're looking at the immune complex assays as well. You're looking at if there's any increase in immune complex in the blood. So referral depends on the patients, what they have. These are some of the specialists you'll be working with and very closely. And we always make a point to see our patients and write a letter within a week or so and include everyone, every doctor that's involved in patients' care, send a letter out to let them know what we're seeing. And sometimes even though we're the one that's adjusting their chemotherapy, their doctors will really appreciate knowing what's going on too. And anytime you see a difficult case, just refer out, and then you don't have to worry about it again. Now we talk to the sort of meat of the lecture. It's a medical management. So the therapeutic principles we follow is number one, preservation of function, right? So you want to treat anything that's aggressive, you want to treat it early, treat it aggressively, and you also want to think about the risk-benefit ratio. Will you put somebody who has HOAB27 uveitis that flares once a year on methotrexate? Probably not. And you also have to understand the diagnosis. You want to say, okay, is this something that can potentially blind them? Just like my lecture yesterday on birdshot. Birdshot is aggressive. You're dealing with birdshot. You really want to put them on immunosuppressive and not just keep giving them Ozurdex and hoping that their disease will just go away. So understanding the diagnosis really makes a big difference on deciding when you want to start treating. And there's the famous sort of the term coined by Dr. Foster is step ladder, the step ladder algorithm, because you move up on the step ladder, going from the easiest to take, the least aggressive chemotherapy to the most aggressive chemotherapy. And you either be an expert chemotherapist or you find one you can work with and use enough and soon enough. And then finally, you always have to document everything with the patients. And especially some of the alkylating agents you're talking about, these are potentially drugs that can make your patients infertile. And you really want to have a really good discussion. And even with any of the chemotherapy you want to talk about, especially female with childbearing age, you want to talk about contraception, things like that. You want to document everything very carefully. Now, acute inflammation, corticosteroids are always the gold standard, and there's nothing better known to us that is better than corticosteroids, and that's why we love it so much, but we also hate it so much because it can come with so many other side effects, and that can be done with drops. We have an infusion center built in our center, so we're able to give people IV Salumedrol if we really need to. Somebody comes in with a really bad flare, sometimes that's what they need, and IV Salumedrol actually has less systemic side effects on the body than PO prednisone, and it really can get the inflammation down very quickly, and sometimes can last a few weeks actually. So, and intraocular injection, periocular injection, and also surgical implants like Ozurdex and Retisert are all steroids. And this is just a table taken from Jab's paper from 2000. This is his guideline on use of prednisone chronic ocular inflammation. So you want to start high. I've seen patients that come in and they got started on 20 milligram a day of steroid. That's not enough. That's inappropriate. We want to go high. You want to go early, 60 to 80 milligrams a day, and then you follow by a quick taper. But I think with acute inflammation, the key is to bring it down and just quiet it down right away, and then you can do the taper later. The last thing you want to do with inflammation is put in a half-baked dose and just let the inflammation linger on, and that's very dangerous, and that makes the disease become more steroid dependent. There's more drops. All the drops are available, I think, to ophthalmologists. And these are actually taken from a recent paper from Survey Ophthalmology written by our group, and I'm happy to send you a PDF copy later if you email me, and this has all these information on there. So a lot of these lectures are actually taken straight out of that paper. So there's the regional steroid preparation. There's a lot of different options. We usually just stick with the Kinalog and triacenes. If we go intraocular, we go with the triacenes in the eye. And systemic cortical preparation. We actually also use subconjunctival Kinalock quite frequently too for scleritis, and even with people with bad pemphigoid flare, we actually would do subconjunctival Kinalock because it works really well. So more or less just more steroids. And so the corticosteroids monotherapy, of course, it comes with the side effects. You have a cataract, glaucoma, delayed corneal healing, infection, conjunctival scleral necrosis, systemic complications, and there's a high risk factor for vision loss. Like I was saying before, if you have patients on steroids and you're not treating the other, you're not treating the disease correctly, then really the patient's still going to experience vision loss. And it really only serves to mask inflammation. You're not really addressing the bottom of the root of the problem, which is in high. I'm talking about non-infectious inflammation here, of course. But if there's infection, you sometimes can also mask the infection too, because I'll show you a table later. A lot of infection do well on steroids to start, but then it never gets better. So here's just a couple more paper. This is, this actually, sorry, there's a typo here. This is not actually a paper from Boston. It's a paper from UC San Francisco. They look at 99 HLA-B27 anterior uveitis patient. They found that topical steroid was associated with 3 times risk of developing these conditions. And use of oral steroids can be associated with vision loss worse than 20/50 during a JIA uveitis cohort. And that's looking at almost 30 years of data. But on the contrary, if you use immunosuppressive therapy, that's associated with decreased risk of vision loss. And now, what about low-dose steroids? You see patients on 5 milligram, and rheumatologists do that too. Rheumatologists, a lot of time, their protocol is, for example, lupus nephritis is, put them immunosuppressive, but you're always on some sort of 5 milligram of steroids. Of course, they try to wean it off, but 5 milligram of steroids can still do harm to the body. There's a paper here that come from Mass General Hospital that show it was a double-blind randomized control study show that prednisone 5 milligrams still suppresses bone formation in healthy postmenopausal women in just 8 weeks. We used to say 3 months of prednisone leads to bone loss. You actually go, I guess it's postmenopausal, so it's maybe a little quicker, but it can still have a big impact. And 5 milligrams for sure in kids are considered pretty high dose, and you're talking about growth retardation. So at Mercy, we really don't put people on PO prednisone at all. Dr. Foster is always known to be very aggressive, and we would adjust our chemotherapy just to get people off steroids, all forms of steroids. Now, the cautionary use is what I was alluding to earlier, cautionary use of steroids. So even in infectious uveitis, steroids can still make things look better at first. Syphilis, you want to diagnose with history and serology. Is it worse on steroids? No, not typically, but you're never going to address the problem. Lyme also, it doesn't get worse on steroids, but also by history serologies, you can diagnose it. With TB, yes, it does get worse on steroids. So you always want, if you think you're dealing with ocular TB, usually this practice, the standard is to get the patient on anti-TB therapy for a while. And get people on systemic steroids if still needed, if the inflammatory lesion is vision threatening. VZV and HSV, again, by clinical exam, you can diagnose them, and it does get worse on steroids too. And Tasso, for sure, it gets worse on steroids, and that's why you always want to start the anti-toxoplasma therapy before you start people on systemic oral steroids. And in ophthalmitis, of course, we all know steroid doesn't make it better. And so whenever there's even a small doubt of infection, you don't want to inject anything near the eye. So when we see patients on that first visit, you just want to say, okay, somebody comes in here with bilateral chronic uveitis, they have macular edema, their vision is 20/200, and you're not sure, and they're going blind. That's sometimes it's tough. Sometimes it's tough. We really want to just talk to the patient and to figure out what's the course of their inflammation. Has it been going on for several months, or is it just very aggressive the last few weeks? Because sometimes it can wait. It can wait for a few weeks before you can wait. You can do all the serologies that I mentioned earlier and really decide whether you're dealing in an infectious process or not. And then you can put it on PO prednisone afterwards. But if you feel like the disease is vision threatening, go ahead and do the PO prednisone. It's okay, because PO prednisone, you can always stop it, and things are usually reversible. But once you do the injection, I have seen an eye turn into a pus ball because it was TB, and the doctor referring didn't think it was TB, and they put steroids around the eye. So PO prednisone IV is okay if you want somebody to get some vision back and you want to just slow down the inflammation, and you just throw in the dice and say, there's maybe a higher chance of being autoimmune, then go ahead and do PO prednisone, get that macular edema down, get their vitritis down, get their vision better while you do the workup. but just stay away from regional steroids. Now, this is steroid-sparing therapy. This is basically what we do, and it's now more widely accepted. However, there's still, there's not enough people that are going to immunosuppressive, steroid-sparing immunosuppressive early and aggressively enough. And even rheumatologists, they had to learn it the hard way. They used to treat all their arthritis patients with steroids, and they know that that's not the way to address these issues. So in 2000, a panel of experts published recommendation in AJO, and that's used on how to use immunosuppressive drugs. And they found that with immunosuppressive, uniformly, they're better control inflammation and decreasing corticosteroid side effects. So when do you use immunosuppressive? I think this is a very important slides here. It's mandatory when, number one, when the disease is potentially life-threatening. So you're talking about Wegener's, or now it's called granulomatosis with polyangiitis. You're talking about polyarteritis nodosa, Behçet's, rheumatoid arthritis. When it's involving the sclera or involving the cornea, it's also highly lethal. Many patients, if you don't treat them with immunosuppressive, they will die. And relapsing polychondritis when this involves sclera, and also retinal vasculitis, and also lupus with retinal vasculitis or choroidopathy. Some of these are, when you see these patients, they have to go on to IMT. Now, the second category when you have to use IMT is potentially blinding ocular disease. So you're talking about VKH, you're talking about sympathetic ophthalmia, multifocal choroiditis and panuveitis, birdshot, and serpiginous. So these are not patients you say, let me just try you on some prednisone and I'll taper you off the next 6 months and I'll hope it will never come back. These diseases do not behave like that. They will come back after you take them out the prednisone. So you might as well start it on prednisone, but also start talking to a rheumatologist or uveitis person to get them started on systemic immunosuppressive. Now, IMT is strongly recommended. They're not always the case, but strongly recommended if it's chronic or recurrent, and these are the diseases that you should consider IMT in. JIA, always sooner than later, and then sarcoidosis. TINU oftentimes is self-limited. You treat them with course of prednisone, they get better, but there are a lot of times where the interstitial nephritis got better, but the uveitis keeps on coming back, and you still treat those patients with immunosuppressive. So the nephrologist may not want to do it, but you need to do it for the for the sake of the eye. Pars planitis and HOA B27 associated uveitis, idiopathic uveitis, and isolated retinal vasculitis with macular edema and also retinal ischemia. Now, a comment on idiopathic, we actually, at Mercy, I would say 65 to 70% of patients we see are idiopathic. So we treat them the same way as we do with the other autoimmune condition. Now, the biologic therapies, we recommend biologic therapies in certain disease. So, for example, in Behçet's, that's actually typically our first line. We like Humira, we like Remicade, and interferon has good results, although we don't use that very often. The biologic therapy can be a second line in JIA. So you start with methotrexate, you start with Cellset, but then you can go to the Humira early if you're talking about JIA. And it could be second line in the other condition once you try anti-metabolites or calcineurin inhibitors. So you're talking about posterior uveitis, panuveitis, severe HOA B27 that recurs very frequently, and then also scleritis. Etanercept or Enbrel has very low of all the biologic therapy. It has for some reason we know now it doesn't work for uveitis or scleritis, so we don't really use it very much at all. And the SIGHT study is a study that came out looking 10 years ago now. They're looking at patients from 5 different academic centers, 1979 to 2005. You're talking about close to 8,000 or 9,000 patients who are on systemic immunosuppressive therapy to treat their ocular inflammatory disease. So you're talking about scleritis, uveitis, pemphigoid, any type of inflammation, keratitis. And they found that in the cancer risk, this is something that patient will read about, they will Google, and they will find, I hear that there's an increase in cancer risk, but you can actually pull this paper. This paper is actually from BJO in 2009 by John Kempen. You can tell them that with anti-metabolites and calcineurin inhibitors, they actually didn't see any increased risk in cancer risk. And alkylating agent, there is actually not a significant risk in cancer-associated risk. TNF and alpha inhibitor is one of the things that's still controversial. There's different literature that says, lymphoma might be more prevalent in people who's been treated with TNF-alpha inhibitor, but a lot of those literatures come from the patients with rheumatoid arthritis, and these are patients that are at baseline had higher risk for lymphoma to begin with. So the data is not very, very strong that it definitely leads to higher lymphoma risk. And which I will mention later too, we're not putting these people on immunosuppressants forever, because just like birdshot, it's active for 10 to 12 years, most aggressive for the first few years. Same thing for a lot of these conditions. They are very aggressive in their 30s and 40s, but those are the years that you can go blind. So we tell patients, no, you're not going to be on these immunosuppressants for the rest of your life, and that's never our intent. Our intent is keep them on immunosuppressants for a finite period of time, get them off steroids, and if we think we can get their immune system under control for 2 years or more, then we start weaning them off the systemic therapy. And we find that we're talking about 70 to 80% chance of success that people can stay off immunosuppressive and their inflammation never comes back ever again. So it's not a word we like to use a lot, especially in autoimmune condition. But we say, we tell patients, you're cured, because you don't need to be on medicine and your inflammation never comes back again. So, and we have a lot of patients like that in our experience, and that's why we don't put them on indefinite therapy. Now, there's a couple conditions like VKH and Behçet's, and sympathetic ophthalmia. Those patients are different. Those patients are one that most likely, and birdshot too, would need to be on systemic IMT for a much longer period of time, because these conditions are just very relentless and they keep on coming back, and there's no way around it. So. But a majority of the time, especially you're talking about idiopathic uveitis, doesn't really have a lot of systemic things going on. We tell patients 2 years, let's set a mark, 2 years. And you also want the patient, you want to give them some hope too. You don't want to say, well, I'm going to be taking these drugs for the next 4 years. 2 years sounds good. 1 year is quick. 3 years seems a little long. So we found 2 years is a pretty happy medium for the patient. And we do find good success after 2 years of drug-free remission. So the stepladder approach, this is the paper I was referring to earlier, which I'm happy to send you a PDF of, and it does mention, it has actually a very comprehensive review of all the chemotherapy we use in uveitis, even ones we don't use. There are 3 pages, a table that would tell you all the drugs that have been using all ocular inflammatory diseases. So this is a figure from that paper, and this is the way we approach our ocular inflammatory disease patients. If it's uveitis, anterior uveitis, and scleritis, we actually will start them on oral NSAIDs. And these are not just oral NSAIDs you take as needed, you actually take it every day for 2 years. So of course you have to worry about kidneys and GI problem, bleeding, things like that. But we typically, for anterior uveitis, non-granulomatous anterior uveitis, and scleritis, we will trial people on 2 doses. Usually it's twice a day dosing, and usually we'll do them just twice a day, every day, not just take it as when you have pain. We actually want to do it all the time, because the whole point is to control your immune system, control your inflammation. If the NSAID doesn't work, then we move on to methotrexate. We went to azathioprine, we went to the mycophenolate mofetil, the CellCept. And just like for our birdshot, sometimes if you need a little additional, we very rarely use cyclosporin or the calcium urine inhibitor as a monotherapy anymore, because Dr. Fosh's experience was that it, as a monotherapy, never gets people to that point where they don't ever need drugs again. So we often use it as an adjunctive therapy. So we would start people with methotrexate, Humira, CellCept, and then add cyclosporin if you feel like, okay, the methotrexate is doing pretty well, but you're kind of maxed out on your dose. You're on 30 milligrams, you're doing subcutaneous injection already. Let me add a little more to get you just over that hump. Because we don't want them to go back on steroids. If you're on methotrexate and you still need steroids, then that tells you you're not really getting the immune system control. So we'll add the calcium urine inhibitor. Now, if that combo still doesn't work, then we go on to the biologic response modifier. And if that still doesn't work, or if the disease is very aggressive, so you're talking about serpiginous choroiditis, that can blind people very quickly. We will go to the alkylators. You're talking about cyclophosphamide or chlorambucil. So the goal is, I already touched on this, but it's complete and total remission of inflammation off all steroids, no topical, no systemic. You want the patient to be very, very, very quiet, and you want to do that for 2 years. So the moment they got off steroids, any type of steroids, that's when we start counting the clock. Okay, so the patient's very eager to get to that point too. So every time they come here, they say, hey, you just make sure you write in your note. I've been quiet since October 2015, so it's time to wean me off. So they will actually always tell you that because they're looking forward to that time when their eyes have been quiet. And we really find that after 2 years of inflammatory control, they do well. They do well. So by the time you wean them off, depends on how many drugs. So we have patients that are on methotrexate, they are on cyclosporin, and then they also come in for Remicade infusion once a month. So those people, obviously, they will be on more than 2 years. You just start cutting the drugs down. If they're on infusion therapy, you start stretching all the infusion length. So there's different. Everyone is different. A lot of patients we actually find they don't want to come out of the immunosuppressive therapy after 2 or 3 years because they've been doing so well and they're nervous. So sometimes they're the one that's telling us not to cut down the drugs anymore. This is a tagline from Dr. Foster. The mission is remission. He gives that line in almost all the talks he gives. Now, just quickly with systemic NSAIDs, these are the typical dosing we use. Naproxen, diflunisal, Celebrex is a good one to use if somebody has GI side effect from NSAIDs, but it can be very expensive. Insurance a lot of time in the States will give us a hard time. So we have to show documentation that the patient's already tried other drugs first. And but that's, again, like I mentioned earlier, it's oftentimes our favorite first-line therapy for idiopathic non-granulomatous anterior uveitis or HOAP27 anterior uveitis, and also scleritis. Whether it's anterior scleritis, posterior scleritis, as long as you don't have anything systemic going on, they don't have like an ANCA titer that's elevated, they don't have lupus or something like that, then you can, if they're just an isolated scleritis, I think it's our favorite therapy to go to. And for that, you have to monitor the kidney function every 6 months. For the disease-modified anti-rheumatic drugs, you're talking about methotrexate, and the dosing can be from oral, subcutaneous, or IV. We typically start with oral just because it's easy. It's once a week. You still have to take folic acid every day. We're starting to tell patients not to take folic acid on the date of methotrexate intake. But studies have shown even if you take it every day, it doesn't really decrease the efficacy of methotrexate. And when do you go to subcutaneous? If it's a kid, they don't like to take pills. You can have the parents do the injection. And also with subcutaneous injection, the absorption rate is excellent. Whereas when you take a PO, a lot of that drug doesn't necessarily get absorbed. So we will do subcutaneous IV. You have to do weekly IV infusion, which is very cumbersome. But for certain patients like sarcoid, if they're having very, very bad sarcoid flare, sometimes just giving them IV Solu-Medrol is not enough, and you have to give them methotrexate 100 milligrams at the same time. Imurin usually 100 to 250, and you have to check the TPMT activity if you ever order this because it can lead to very severe bone marrow toxicity. It's just a gene, it's an enzyme activity. Some people are just inherited. Cellset, mycophenolate mofetil, you're talking about 500 to 1500 milligram BID. That has to be taken on empty stomach, usually 1 hour before, 2 hours after a meal, and it's actually very well tolerated. And the most common side effect is GI upset or mood swing. And cyclosporin, 50 to 300 milligram a day, and you're talking the most common side effect is kidney problem, hypertension, hyperlipidemia. You can get swollen gums, bleeding gums. So we tell patients to see their dentist and floss and do their water pick treatment, and hirsutism, which is just mean hair growth on the face and the body. So women, we always have to mention that to them. It's not typically used as monotherapy, but we do not check the trough level. Rheumatology will do that. In post-transplant patient, they would do that. But in our practice, we don't typically do it. A lot of uveitis people don't do the trough level because it's pretty cumbersome to check. And also, if it doesn't work, then you just go up on the dose, and it's more important for kidney transplant patient because you don't want to give them too much cyclosporin, which in turn will hurt the kidney. And the biologic response modifier, you talk about Remicade. We usually start with 5 milligram, and then we can go up to 10 milligram if we need to. We usually double the frequency of what's used in RA and Crohn's. We actually do it every 4 weeks. Humira is 40 milligrams self-injection every 2 weeks, but we often need to go to every 1 week as well. Rituximab, the therapy, the protocol we use is pretty new. We actually were the one that came up with this protocol, and that originally from our paper from 2010 on very treatment-resistant ocular cicatricial pemphigoid. We use a combination of rituximab and intravenous immunoglobulin, and we do that. So we would do actually rituximab once a week for 8 weeks, followed by once a month for at least 4 months. So they're talking about 12 infusion of rituximab. And just for comparison, if you're talking about rituximab treatment for rheumatoid arthritis, they usually just do it once, and then once again in 2 months, and then that's it. And then they sometimes they do maintenance dosing every 6 months, something like that. But we use it very aggressively. Tocilizumab is Actemra. You can do that 4 to 8 milligram per kilo every month. And again, Enbrel is not effective for uveitis. And alkylating agents, these are drugs that I don't personally like to play with a lot. Dr. Foster feels pretty comfortable doing this. He's been doing it a long time. I still get a little nervous when I feel I need to do these because when you're doing the alkylating agents, you have to do it in a very controlled way. You are drawing their blood. You're having the patient draw their blood every week to every 2 weeks because you are shooting for a very narrow white blood cell count windows. You're aiming for 3.5 to 4.5. So you're making them a little leukopenic, but not too leukopenic. So you have to do it very, very carefully, and you adjust your dose based on that. And the weekly blood monitoring is a must, and we typically don't put people on more than 7 to 9 months. Because sterility is a really big concern, and also the possibility for the cancer risk, although in the site study they didn't really see a big difference in the cancer from the alkylating agents. So these are reserved for the most life-threatening. You're talking about Wegener's. If somebody comes in with bad Wegener's with hemorrhage and pneumonitis, or ocular blinding disease, how it comes in with serpiginous. Those are some of the things we will use alkylating agents for. Now, the other therapy, you're talking about IVIG, that's usually cumbersome, very expensive. It's a once a month infusion, but you're doing it over 3 days. So it is our preferred therapy for patients with very severe ocular cicatricial pemphigoid in combination with rituximab. Interferon, again, good success in Behçet's and people with MS-related uveitis. But we don't really use it just because there's a lot of side effects, flu-like symptoms patients can get. And the HP Actar gel is an old drug that's been sort of brought onto the market more recently by the Irish company Mallinckrodt, and we are testing that in some of our trials in retinal vasculitis patients. And it is a drug that stimulates your natural cortisol production, and because it activates different kinds of receptors, it also exerts the anti-inflammatory effects, but without causing the corticosteroid-related side effects. So we'll see. I think it's been truly approved for infantile spasm. And there are cases that show it works for people with multiple sclerosis or people with diabetes who has sarcoidosis, and they use it for sarcoidosis, but their sugar stays actually relatively normal. So we'll see how it goes. But this is one of the other therapy that's worth mentioning. So for an exhaustive list of these agents, this paper has it all. There are many pages and it actually tells you, it sort of gives you all the key points, what labs to look for, how quickly do you expect it to start working, what kind of lab tests, what kind of side effects to ask your patients for. So this table has it all. And here's my email, so just email me later if you want a PDF copy of it. I'm happy to forward it along. So now that we're through the uveitis treatment and stuff, what about cystoid macular edema? Now, we always want to make sure the uveitis is quiet. If the uveitis is active, then forget about it. You can blast the eye all day you want with anti-VEGF. It's never going to work. It's just going to keep coming back. So what we do is once we get the eye quiet down, if it's not a bad CME, you got a couple cysts here, the patient is 20, 30, then you can do topical NSAIDs. And then if it's more severe, you still put it on topical NSAIDs, but you might want to get the patient over the hump with a little bit of periocular steroids. And if they're pseudophakic, they're older, they're on way to get cataract surgery anyway, then we sometimes will use intravitreal steroids as well. And Ozurdex, again, we don't use Ozurdex to treat uveitis, but we do use it for uveitic macular edema once we think the inflammation is already controlled on systemic therapy. And then, of course, anti-VEGF works very well if you get the inflammation under control. A lot of time I will combine Avastin and steroids together. So that's a higher dose. You're talking about 0.1 cc of steroids, that's about 4 milligrams. I would do 0.1 cc plus 0.05 cc of avastin. So you're putting 3 times of what you usually do for anti-VEGF in the eye. So you usually want to do a little AC paracentesis. Intravitreal methotrexate also, it works actually quite well. It's cumbersome to keep in the office. You have to keep it in dark, and once you open it, you have to use it within 24 to 48 hours. So you really, it's not, we have methotrexate in the office because we do injection for our patients, we do infusion if we need to, so we can easily mix it for intraocular use. And subcutaneous octreotide or sendostatin is something that there's only very limited case series, but one of them was by Dr. Foster, and he likes it. It's a subcutaneous, subcutaneous injection monthly, self-directed injection. And also interferon has really good effect on macular edema as well. So if you're treating MS, you're treating Behçet's, even Behçet's who have bad macular edema, interferon actually can do pretty well as long as the patient can tolerate it. Now, about surgery, Retisert is always a good one to go to if somebody just has chronic, either their inflammation is chronic and they're not responding to the systemic immunosuppressive therapy, or they just don't tolerate the therapy, then you can do Retisert. PPV with IO-MPO, and there was a very nice presentation earlier. I can't say too much. I'm starting to do them on my uveitic macular edema patients, and I think the results so far in the limited case series that we have in uveitis, I think the results are similar to what they say in diabetic too. You get great anatomical results, but the visual acuity is, so-so. Doesn't always guarantee visual recovery. And there's an excellent review in this paper here talking about all the treatment for uveitic CME. And inflammatory choroidal neovascularization, of course, anything that can cause scarring or choroidal granuloma, you can get CMV. And the most common ones are multifocal choroiditis and pin uveitis, PIC, serpiginous, presumed ocular histoplasmosis syndrome, and toxoplasma. The last common, Behçet and sarcoid. Now, you can do PDT with verteporfin, and the success rate is about 80% in case series. And you can also use anti-VEGF or sometimes a combination of both, plus or minus intravitreal steroids. So I think I'm gonna stop here. The rest is, if you're interested, I can send you more, or we can talk more. But these are basically slides from my colleague Steve Anisi. He does most of the cataract and glaucoma procedure for our practice, and this basically just goes into sort of surgical principles. I think basically the take-home message is that you really ideally want to wait 3 months before uveitis, when uveitis is quiet, and then you can go ahead and do your cataract surgery. You can have your colleague do the glaucoma surgery, but really the eye should be quiet for 3 months. And then basically we just went on to talk about the IOL implantation. We like IOL implantation actually. It used to be sort of almost forbidden, especially in kids with JIA uveitis, but it actually has great results. If you can control the inflammation, get them on good, solid, aggressive systemic immunomodulatory therapy, there's no reason why you cannot implant a lens, especially with the modern lens design. There's no reason why you cannot put a lens in somebody with history of uveitis. And we actually have good outcome on people who use a multifocal IOL. As long as they don't have any macular pathology, they do great, and these patients are just as happy as non-uveitic patients. So I think that's about it, and I'm going to just skip over the glaucoma stuff. The point to make, Steve wants to make here is 2 shunts were better than trab. But if you ever want to do trab, express shunt is a good idea because it can keep the sclerostomy from scarring down. And finally, I just want to touch really quickly on there's also worth mentioning is there's different kinds of intravitreal therapy. So methotrexate, like I mentioned earlier, is good for uveitic macular edema. We also use it for intraocular lymphoma along with intraocular rituximab, and now people are using it in PVR. I've done a couple of PVR cases where I have to put oil at the end of the case, and it's actually safe to inject methotrexate, and usually that's 400 microgram per 0.1 cc. It's actually safe to put it in with an oil, and there has been some reports of methotrexate preventing PVR recurrence. And the sirolimus, the Sakura trial, this one is awaiting FDA approval, and I think this would be a great drug to incorporate when you're dealing with patient that comes in with a sudden flare of their posterior uveitis that has a lot of vitreous haze, and the drugs itself is not going to cure the uveitis, but it's going to decrease the vitreous haze significantly and getting people, it's almost like when somebody comes in with anterior uveitis, you put them a lot of topical steroids, but then you say, okay, but how do I get rid of the haze? Is the only way to give them prednisone or injection of steroids? Well, I think this will be the very, very excellent alternative because it has no risk of glaucoma, no risk of cataract, as long as the needle goes into the right space, and has a very good, I think it will be hopefully we'll hear from at least from the American side, hopefully we'll hear from the FDA whether this will be approved for posterior non-infectious uveitis. I think that's going to be an excellent drug to have. And there's also other couple investigational targets. So there's a very good comprehensive review on all the intravitreal therapy on this paper here. And finally, Retisert, which I touched on yesterday. I have seen a lot of Retisert dislocation, and I'm sure some of you have. I just want to mention here the way, usually the time to dissociation is 6 to 9 years after the implantation, and it's sad because the implant only works for 2.5 years, and so the patients think they're doing great, and then suddenly they have an implant dislocation. But this is just the way we like to do our removal. If somebody's aphakic, the Retisert can come to the front and cause corneal edema, and that way it's easy, you just take it off the cornea, but you want to do it soon because it can kill the endothelium. But if somebody is pseudophakic, then my favorite method is actually just make a large wound. You can use the old wound of where the suture strut sits, but you just have to make sure the suture strut comes out. Otherwise, if you cut the wrong suture, the suture strut can also go into the eye as well. So you can either use the old wound or you can create a new wound. But I think the key here is to make a very large incision here, about 5 millimeter. To put it in, you only need about 3.5 millimeter. But to really make it come out, you really need a large. I would use a soft extrusion cannula. It actually sticks to the implant very well. It's very hard to grab the Retisert pellet with forceps. Just the angle of it is just not right. Unless it sits on the macula just the right way, it's very hard to actually get a grip on the implant because it looks like a UFO disc. So you want to come from the side and get it. But if you use a soft extrusion cannula and just floor the extrusion and then turn the intraocular pressure to 60 or 70. Just let the eye just pump crazy amount of fluid in there, and then have your assistant just suck. You use an extrusion cannula, suck the implant toward the wound, and then have an assistant open up the lip of the wound for you. The thing oftentimes just shoots out. It can take 5 minutes. Otherwise, if you make a small wound, you can struggle all day. And finally, this is the last part of my talk, just Iluvien, and we know it's approved for diabetic macular edema, and I think it will be approved for uveitis very soon. I'm not sure, but I think in Europe they filed the marketing approval back in June, and in United States they're going to file for posterior uveitis use later this year. We are involved in the phase 3 trial at Mercy, and we have very good outcome for people who got Iluvien. It's basically just a lighter version of Retisert that doesn't have as much glaucoma and cataract complication. I mean, cataract ultimately you're going to have it, but I think less likely to have glaucoma because it's a slower, lower dose release. And we have seen very good outcome on people who get Iluvien for posterior or panuveitis. And that's it. Oh, and sorry, there's one last thing I want to touch on pars plana vitrectomy, since you're a retinal surgeon here. The only time we really use pars plana vitrectomy for treatment of uveitis really is we either do a diagnostic vitrectomy if you're looking for intraocular lymphoma, then we are looking for, or you want to look for some other infectious etiology, but for intraocular lymphoma, these are the 3 tests we look at. We look at the interleukin 10, interleukin 6 ratio. I think it's very effective. When a 10 is high, that's more likely to be malignancy. When a 6 is high, that's more likely to be autoimmune. And you look for B-cell lymphoma, which is typically the type of lymphoma we see in the eye, you look for the IgH heavy gene rearrangement, and for the T-cell lymphoma, you do the TCR, the T-cell receptor gene arrangement by PCR, and then of course you want to send undiluted vitreous to a very experienced cytopathologist to look for the very scanty lymphocytes that they might be able to give you a diagnosis. But we like to do all 3. We like to send samples to do all 3, and sometimes you're not going to get positivity on all 3, but even if you just get 1 or 2, that really makes you more likely to treat it as intraocular lymphoma. Of course, we do it for visually significant vitreous debris and pars planitis. Here's just a picture of my trying to fix a PVR retinal detachment under one of our ocular cicatricial pemphigoid patient with K-Pro. It's just never fun, with ocular inflammatory disease. It's the anatomy is very, very different. But this patient did well because he's on very aggressive systemic immunotherapy, so his pemphigoid never flared up after I went into the eye a couple of times to fix his PVR. And his conjunctiva actually stayed beautifully quiet. And finally, we do pars plana vitrectomy on pars planitis. I think it's a great therapy, just like people do cryo to treat pars planitis. In our view, if somebody comes in, a young person comes in with pars planitis with no systemic issue, it's just idiopathic pars planitis, if you do an angiogram on them and you see retinal vasculitis, then we usually recommend doing immunosuppressive therapy because we don't think the vitrectomy alone will take care of the vasculitis and the possible associated macular edema. But if the angiogram is completely quiet, looks perfect, and all it is just a bunch of snow banking, vitreous debris, and cells, and they're really driven crazy by their floaters, that's when we would do pars plana vitrectomy, and then we will indo laser the inferior pars plana. Sometimes you have to do, a lot of time you have to do cryo as well because those young people are phakic. So you don't have to hit the lens. So these are really the surgery we do. Now, even with people with vasculitis, we have done vitrectomy before, and we found that there's an overall reduced burden of immunosuppressant needed after the surgery, and we think it's because by removing the vitreous, you're removing this gel that traps all the cytokines, and that may also, excuse me, also alters the blood-ocular barrier to allow more systemic immunosuppressives to get into the eye and maybe let the inflammatory cytokines to leave the eye. So that was just our hypothesis. So these are typical slides from Dr. Foster's talk. He would go on and talk about how he thinks there's still a lack of uveitis in the world, but as we all know, I think it's getting better. People are getting more and more recognized, and there's more properly trained uveitis specialists, and we're always here to, offer a consultation and it's always great to hear about cases from all around the world and share our opinions with people. So thank you very much again to allow me to be here, and thanks for staying late and not fall asleep. So thank you. Any questions at all I can answer? Oh yeah. The most important one. No, it's
May I ask you a question?
I can give it, but it's it's just pchang@mercy.com. Yeah.
I just want to learn your approach for choroidal neovascularization associated with inflammatory diseases. You have given your outline actually. I think you prefer to do PDT first.
Oh, no.
And then the others. Can you give me a flow chart for that? For example, multifocal choroiditis or PIC, something like that.
Yeah, no, sorry. I actually didn't mean, I think I did a sort of histological, historical, the time, that's how, but I think we still do anti-VEGF first. Yeah, we always do anti-VEGF.
Not steroids?
Intravitreal steroids, possibly, if we think the lesion is inflammatory and it's not just a CMV that just grow from a scar, then yeah, I think, if, for example, the PIC lesion, if there's an active inflammation seen on FA or fundus autofluorescence, and you also have a CMV associated, then we put steroids and the VEGF together.
If it is secondary to a scar, then the first is anti-VEGF.
Anti-VEGF, yes, correct. And then if they need a lot of injection, then that's when I would bring up the PDT with them.
Okay,
yeah.
Thank you.
No problem, thank you. Thanks for pointing that out. Yeah.
Can I ask you a question? Litvinchuk, Germany. So you pointed out that in order to treat macular edema, not CNV, but edema, anti-VEGF could be used. And what is the purpose? Because in such a patient, we were thinking about anti-VEGF, but we did the measurements of VEGF in an anterior chamber tap. It was not increased.
Yes. So I think in this case, it works by just decreasing the permeability of the vessels.
But this occurs secondary to the VEGF receptor block.
No, I think it's, I think it works as long as the the inflammation is under control. I know uveitis is not it's not a VEGF-driven process for sure, and that's why I personally don't. If somebody just comes in and with that anti-VEGF is actually not my typical go-to therapy. I would do steroids first, and that's why I oftentimes will combine both of them. But I agree with you, it's not a VEGF-driven process, but it works. It works once I think the inflammation is under good control. It still works very well.